Thank you, Sandra, for the invitation to speak, and I'll just be giving a short overview of the role of radiotherapy in osteosarcoma. So, local therapy in osteosarcoma. Local control is everything, as we know, and it's essential for long-term survival. And generally speaking, local therapy is surgery if it possibly can be. When do we give radiotherapy for osteosarcoma? We can either give it post-operatively after surgery, or we can give it instead of surgery. So just briefly, talking about post-operative radiotherapy, we tend not to give it routinely. Times when we might think about it are for close or positive surgical margins, maybe for a poor histological response to chemotherapy, maybe for pathological fracture. But I put question marks by all of these because actually I don't think we understand very well which patients should we give post-operative radiotherapy to and what's the benefit for them. So the other situation when we might give radiotherapy is as definitive radiotherapy. And so this is instead of surgery, and this might be if surgery is not possible for an inoperable tumour, and as Craig alluded to, there's a lot of definitions around what does inoperable actually mean, or if surgery is declined by the patient, if for whatever reason it's not acceptable to them. And usually the scenario is that this is going to be sacral tumours or pelvic tumours where surgery is very big and morbid. Now, osteosarcoma, we know it's a radio-resistant tumour and it requires high doses, so at least 70 Gray or more to try to achieve anything in terms of local control. And that's really the challenge. How do you deliver these high doses? Now, in the past, local control rates have been very poor with definitive photon radiotherapy, and this would have been with 3D conformal radiotherapy. And this is just because of the limitation of the doses that you can get in with that kind of 3D conformal technique, because of the concerns about overdosing normal tissue structures. So this is an old paper here from 2003, patients treated with photon radiotherapy with a median dose of around 60 Gray, which is a reasonable dose. But you can see 16 out of 17 patients with pelvic osteosarcoma receiving radiotherapy alone failed local control. More recently, we've had technical advances which have improved outcomes for patients really because of being able to deliver higher radiotherapy doses. And there are two broad approaches. So there's use of photon intensity modulated radiotherapy, which allows shaping of the radiotherapy beams to conform better to the tumour, and that allows dose escalation. And the other way that we can dose escalate is with using particle radiotherapy such as proton, beam or carbon ion therapy, which is actually using specific beam characteristics, again to spare normal tissues and to allow the dose escalation that we need for osteosarcoma. So just a little bit on intensity modulated radiotherapy. So this is photon X-rays essentially, and as I said, it's shaping the delivery of radiotherapy to conform to the tumour. So we have better conformality. We can treat the tumour with better homogeneity, but also we can, if we want to, we can vary the dose across the tumour if we want to give certain areas higher doses, and this is the dose painting concept. All of this allows us to spare normal tissues better and to reduce normal tissue and acute and late toxicity. And so this allows dose escalation, aiming to improve local control, hopefully, and therefore overall survival. And so this is just an example to show you what I'm talking about. So this was an IMRT photon plan for a patient who had an osteosarcoma of the pelvis, a large tumour, and we were able to deliver 70 Gray to this tumour. If we'd done it with a 3D conformal plan, because of the bowel in the pelvis, we would have been able to deliver 50 Gray at best, which would have been completely inadequate. What are we doing in terms of research in using IMRT? So we've got a national radiotherapy protocol running at the moment, which is the IMRIS protocol, and this is looking at the role of intensity modulated radiotherapy in sarcoma in general, but is specifically looking at some bone sarcoma cohorts as well. So this is a prospective phase 2 study which is running in many centres around the UK. Just to highlight that the protocol was developed with a BCRT funded research fellow. The trial's been funded by CI UK. And for the purposes of today, cohort 3 is a primary bone sarcoma cohort of patients with sarcomas of the pelvis and the spine, and specifically including osteosarcoma patients, and really asking the question, can IMRT be successfully used to deliver higher radiotherapy doses than we could achieve with a standard 3D conformal photon plan? Can we get doses in of 70 Gray or above, and what can we do in terms of achieving more durable local tumour control? And the recruitment is ongoing. So just changing tack a little bit and moving on to particle radiotherapy. So what's the big deal about particle radiotherapy, and why is everyone really interested in it? Why are we building 2 centres in the UK? So just to explain, if you look at the grey line here, so this is essentially looking at dose distributions of different types of radiotherapy. So this is the relative dose and this is the depth in the body. So if you've got a standard photon beam, then you get an initial dose build-up to a few centimetres to a peak, and then you get a gradual attenuation of the beam as it travels through the body and it comes out the other side. So you continue delivering dose at depth as the beam travels through the patient. So here you've got protons in green and you've got carbon ions, which are the 2 modalities that I mentioned. And so what you have is your incident dose is lower here. It then travels through the patient at a low dose, then you get a very sharp peak, which is the so-called the Bragg peak, and you deposit the majority of your dose on the tumour, and then you get a really sharp fall off. And so you're not getting the downstream dose, so you're not getting the exit dose through the patient, and that's really the crucial thing in terms of being able to treat the tumour but not the normal tissues, and that's what allows dose escalation, which is what we need for osteosarcoma. And just to illustrate that, so we have on the left, this is a proton plan delivering craniospinal radiotherapy for a child, and this is on the right, this is the X-ray photon plan. And what you can see is that with the X-rays, yes, you're treating the spine really nicely, but you're delivering a whole lot of dose to the rest of the body, whereas for the proton plan, you're getting this very sharp fall off, so you're sparing the vertebral bodies and you're sparing the rest of the body. So that's the principle of particle radiotherapy. So what about protons? So as we said, it's this very specific beam characteristic, the Bragg peak, which allows dose escalation, and so we hope that will allow or achieve long-term local control. Now what I would say is that what we don't know is proton radiotherapy better than high-quality intensity modulated radiotherapy? Because actually what we know is that we can deliver very similar doses with a good IMRT plan. We also know that protons and photons radiobiologically are equivalent. So the RBE, which is the radiobiological equivalence ratio for protons to photons, is 1.1. So I think a sort of misconception is that protons are somehow stronger than photons. No, they're not. The radiobiological equivalence is the same. And so this is something we don't really know. I think everyone thinks protons are better, but we don't know that at all. In terms of what about protons in the UK, up until about last week, we didn't have proton radiotherapy in the UK, but as I'm sure many of you know, we've been building 2 proton centres, one at the Christie in Manchester and one in London at UCH, and the Christie has just gone live and is starting to treat the first patients, and the London build is a bit later. It's a more complex build, and that's going to go live in July 2020. So we will have the opportunity to deliver more proton radiotherapy than is possible at present. At present, a small number of patients go abroad for treatment. And this is just to give you some examples. So this is a patient with osteosarcoma of the sacrum. So on the left, we've got an IMRT plan. On the right, we've got an intensity modulated proton plan, IMPT. And so what you can see is actually in terms of delivering dose to the tumour, both do it really nicely. The advantage of the proton plan is you're not spraying a whole lot of dose through the rest of the body. And the advantage, if you're trying to give really high doses, is you may be limited just in terms of the normal tissue structures. So for the pelvis, it's going to be bowel, and it's going to be bladder, and it's going to be rectum. Just to give you a sort of a rough idea of what can you achieve, or what can we achieve in osteosarcoma. So this was a series from Mass General who've been treating with protons, particularly for sarcomas, for many years now. So this was a series of 55 patients treated to a median dose of 68 gray, and they've got a 5-year local control of 72%, although this was a mixture of patients who had inoperable or incompletely resected tumours. So 58% of patients still had surgery as a component of treatment, and as we've said, surgery is really important and really effective. So this is not a pure 72% local control for proton radiotherapy figure. And just to mention carbon ion therapy, again, we've seen that the beam characteristics very similar to protons, with the Bragg peak and the very rapid fall off, and that's what's allowing the dose escalation. The difference between carbon ions and both protons and photons is this: the RBE, the radiobiological equivalence. So essentially the RBE is 3, which is essentially saying that carbon ions are 3 times as effective biologically or radiobiologically as protons and photons. So you're getting more bang for your buck with carbon ions. Now, having said that, carbon ion facilities are much less common than proton facilities. Japan have had carbon ion facilities for around 20 years. They really embraced it, and they've got about 5 or 6 facilities, and actually many proton facilities as well. There's a few in China, 1 or 2 in America. In Europe, we've got Heidelberg, and there's also a centre at CNAO in Italy, Pavia. So the access to carbon ions is much less. Again, just to give you an idea of what can you achieve in osteosarcoma. So this is a series from Japan, from Chiba, unresectable osteosarcoma of the trunk. So this is pelvis, spine, paraspinal. None of these patients had surgery at all, so it's a pure radiotherapy series. But you can see you've actually got a 5-year local control rate of 62%, which is actually pretty impressive, and is better than protons, and is definitely better than is achievable with photons. So I think, for me, carbon ion radiotherapy in terms of dose escalation and the higher RBE is potentially really important for radio-resistant tumours such as osteosarcoma. And this was just to show a carbon ion plan. So that's the tumour there, and that's what it looks like after some years after radiotherapy, carbon ion radiotherapy. So what are the research questions? What are the things that we don't know? And I've sort of covered some of these in the talk. So how does PBT, proton radiotherapy, compare to good quality IMRT photon radiotherapy in delivering equivalent doses? Is it really better, or actually can we achieve a lot with IMRT? What about carbon ion therapy? How does it compare with proton beam therapy? And is there an advantage for the radio-resistant tumours such as osteosarcoma in terms of dose escalation and long-term local tumour control? Certainly the early results from Japan seem to be suggesting that it is superior to other forms of radiotherapy. And then I've listed at the bottom, boring but important, is questions around what is the role of post-operative radiotherapy in osteosarcoma, because we don't really know when we should be using it and what it's achieving. And actually the importance of ICONIC is collecting prospective radiotherapy data to understand what are we doing, who are we treating, how are we treating them, what do we think it's achieving. If you look at the literature on this subject, there isn't any, so trying to work out from the literature, there's no information. So what are the current protocols for radiotherapy in osteosarcoma? At the moment we've got IMRIS in the UK, and there's also a protocol running in Heidelberg, which is a phase 1/2 study looking at safety and efficacy of heavy ion radiotherapy for osteosarcoma. And so that's looking at both proton and carbon ion radiotherapy. But what I'd point out is that when I checked on clinicaltrials.gov last night, Recruitment is listed as being over 10 years and aiming for 20 patients. So it's hard work recruiting these patients and getting information. There's not very many patients. And so I think the challenges, as for, I mean, Craig was talking about the challenges of surgery, the challenges of radiotherapy, is how do we investigate in a timely way in such a rare tumour, and when we're only using radiotherapy relatively infrequently, how do we ask randomised questions in such a rare tumour? And if we can't ask randomised questions, because I think that's really difficult, what are the alternatives to randomised questions? How can we still gain information on radiotherapy delivery and effectiveness in osteosarcoma? Thank you.